Myself. Yes, my comrade here, Kristen. We did a good job, Kristen. Every time I look at it, I'm like, oh, we did such a good job. I'm going to get us started out of respect for the time and out of respect for Dr. LaVeist and all of you who arrived on time. Thank you for being here on this wonderful Thursday morning before we have a snowstorm here in New Jersey this weekend. I just want to say thank you to Dr. LaVeist, to Dean LaVeist, for joining us. You know, there's many honors I have being the Dean of the School of Public Health at Rutgers. One of the honors is being able to work with some really amazing individuals around the country. Particularly folks like Dr. LaVeist, who are thinking in innovative ways and pushing the boundaries and really helping us bring, public health into the 21st century, health, the 20th century, and helping us advance the way we think about social inequities and the drivers of disease and health in our society. So I'm honored. I also serve on the board of directors with Dr. LaVeist, so I know how incredibly busy he is. Dr. LaVeist, thank you for being here with us this morning. It is our pleasure to welcome you. And I'm going to turn it over to Kelly Kohler, who is going to do a formal introduction.
Thank you. All right, so we'll go ahead and get started. I'm really excited to introduce everyone virtually here today to Dr. Thomas LaVeist. He's the Dean of the Tulane University School of Public Health and Tropical Medicine, and he is the Weatherhead Presidential Chair in Health Equity. Dr. LaVeist is a leading health disparities researcher on topics such as health and social policy, the role of race in health research, and social factors contributing to health services utilization and outcomes. Before moving south to Tulane, Dean LaVeist was previously the chair of the Department of Health Policy and Management at the Milken Institute of Public Health at George Washington University. And before that, he was the director of the Hopkins Center for Health Disparity Solutions during his tenure at Johns Hopkins School of Public Health. Dean LaVeist has won numerous awards and honors and is an elected member of the prestigious National Academy of Medicine. He's also a proud alumni of the University of Michigan and has a few fans and fellow alumni in the audience today. Dean LaVeist has been a fervent voice in a national media calling attention to COVID-19 and was named as co-chair of the Louisiana COVID-19 Health Equity Task Force by the Louisiana governor. Through the task force and his own social marketing campaign called The Skin You're In, Coronavirus and Black America, he is dispelling myths and raising awareness in the Black community about staying healthy in the midst of this pandemic. And so from the Rutgers School of Public Health and the Are You Here steering committee, we are really excited to welcome you, Dr. LaVeist. Thank you so much.
Well, thank you. Thank you for the invitation. It's so strange to hear Perry refer to me as Dr. LaVeist. I tend to be a more of an informal person as he. So that was and I really wish I could be there in person. I'm originally from the Northeast and always enjoy opportunities to get back there. I don't enjoy hearing that there's going to be a snowstorm coming through. And I'll tell you one thing I miss a lot about living in the Northeast, such as good pizza and bagels, mostly, more than anything else. But what I do not miss is the snowstorms that you endure. And so I do appreciate being here in Louisiana for that reason alone. Thank you for the invitation. Wish I could be there in person, and maybe we could get through this pandemic and one day get back to in-person meetings. Look forward to that. I actually have a lot that I want to say. Had to think long and hard about what to cut out and with the time that I have allotted. So I'm going to try to get through this quickly because I do want to make a number of points, and looking forward to the dialogue, especially in hearing more about what's happening there in New Jersey as it relates to COVID and your experiences with race. So let's start by just kind of going over the timeline a bit of where we've been with this pandemic. The first confirmed case of COVID-19 was on January 21st of last year, 53 weeks ago from today, in Seattle, Washington. 10 days later, the World Health Organization declared a global emergency. The next day, the Surgeon General tweeted this: roses are red, violets are blue, risk is low of coronavirus, but high for the flu. So get your flu shot. So while I clearly agree with the sentiment that you should get the flu shot, the suggestion that coronavirus risk was low was certainly premature. 2 days later, after that tweet, the US declares a public health emergency. 5 weeks later, the World Health Organization declares COVID-19 a pandemic. 2 days later, the Trump administration declares a national emergency. Shortly after that, the Surgeon General comments that next week is going to be our Pearl Harbor moment. It's going to be our 9/11 moment. It's going to be the hardest moment for many Americans in their entire lives. This was in April. Again, not very good prognostication skills in the government. That month, we started to see rumors perpetuate that Black Americans were somehow immune or would be less affected by this pandemic. This, in spite of the fact that we had well-publicized stories about celebrities that had come forward indicating that they had been infected and had a difficult time struggling with that disease. Also in April, we started to get the early findings on race differences in COVID deaths, finding stark differences at some locations, such as Louisiana. 70% of deaths were African-American, while only 32% of the population was African-American. Now, these were early data that proved to be inaccurate. And after the data has been cleaned up and we have more reliable data now, we see that while the disparities are not as big as those early findings suggested they would be, that there are, in fact, dramatic disparities. This is data as of yesterday. The response in many states was to create task forces to work on COVID-19 and health equity. Louisiana made the questionable decision to appoint me as co-chair of their task force. Other states made even more questionable decisions about who to head up their efforts to address COVID-19 and health equity. But again, the federal government continued to play a role in pandemic response that was, let's just say, problematic, suboptimal. The Surgeon General that month commented that you should avoid alcohol, tobacco, and drugs, and call your friends and family, check in on your mother. And speaking of mothers, we need you this. If not for yourself, then for your abuela. Do it for your granddaddy. Do it for your big mama. Do it for your pop-pop. We need you to understand, especially in communities of color, we need you to step up and help stop the spread. So this narrative, the disparities in COVID was a function of underlying health conditions resulting from the fact that people of color did not do a good job of taking care of themselves because of high use of alcohol, tobacco, and drugs. And this is what was producing the disparity, became the narrative that began to circulate. Even though there was evidence, at least anecdotal evidence, that racism was playing a role in these COVID deaths. I see stories here of a Black female physician who died of COVID after complaining that her care was suboptimal, and she supposed that suboptimal care was a result of racism. So we have these two narratives about why the disparities exist in COVID deaths. Narrative one is that this is about the individual, about the blaming of the victim. So African Americans have high rates of chronic conditions. They smoke, drink, don't exercise, don't take good care of themselves. They accept myths about immunity. And as a result, they don't take good care of, make good decisions to protect themselves from the virus. And then there's this other explanation, a more structural explanation, one that I found to be more compelling, because as I looked at the data on chronic conditions in Louisiana, where I live, I see that not only do African Americans have very high rates of obesity, hypertension, diabetes, COPD, asthma, conditions known to be complications if infected with SARS-CoV-2. But I also know that while African Americans in Louisiana and here in the South have very high rates, I know that whites here in the South have extremely high rates as well. And in some cases, whites in the South have higher rates of those conditions than Blacks living in other parts of the country. So if the disparities in COVID death was a result of these underlying health conditions and the disparities there, then the disparities in COVID deaths would not be nearly as big as they are. There had to be something more than just individual level decisions and lifestyle. You look at who was bringing you your food when you were at home quarantined, calling Uber Eats to bring you food. It was disproportionately people of color. We also know that African Americans do have distrust of government and distrust, therefore, of the vaccine, which we'll talk about in a moment. That distrust, I think, is structural because it comes from structural factors that led to the distrust. I see the distrust as being logical, a logical response to 402 years of untrustworthy behavior. I look at government policies. For example, many states here in the South, like Louisiana, have right to work or right to work states where workers do not have access to union protections for occupational safety, where much of the spread was occurring. I also look at states like many states here in the South that have not expanded Medicaid, and as a result of not expanding Medicaid, have a higher number of people who are uninsured than they otherwise would have. And in many cases, states have lost a large portion of its healthcare infrastructure due to hospital closures as a result. And we also see suppressed wages here, meaning that people have fewer economic resources than they otherwise would have, and therefore are less able to mitigate the impact of the pandemic. But perhaps the biggest and most important part of the infrastructure that leads to the differential effects that the pandemic has had has been the fact that we all may live here in the country together, but we live in segregated communities. And as a result, the infrastructure that supports the ability for harmful factors that are harmful to health to be spread in one community and protective factors to be available in another community is supported by this issue of segregation. So let's talk a little bit about segregation. This is a map that was produced at the University of Virginia based on the 2010 census. This map places a dot representing the residents of every American. So they have 330 million dots. The dots are color-coded so that blue dots are representing white Americans, green dots representing Black Americans, Asians are represented by red dots, and Hispanics by orange dots. This is the entire nation. So now let's go into one city. This is Washington, D.C., the nation's capital. If you look at Washington, D.C., you know this is a relatively small geographic area that we're looking at here, we see that clearly the green dots are to the east of the city and the blue dots are to the west of the city. And there is clear segregation in where people live on the basis of race. Robert Wood Johnson Foundation created this map based on the DC Metro, which depicts, I think nicely illustrates how this operates. So if you are in the center in the city at the Metro Center Metro stop, which is where I used to catch the train on my way home when I was at George Washington University, the life expectancy in that area is 72 years. Depending upon which train line you get on, which subway line you get on to go home, we can predict your life expectancy. So if you get on the red line and go out to Montgomery County where you live, life expectancy is 81 years. If you're on the orange line or the blue line and you go into Northern Virginia, likely your life expectancy will be about 80 years. But if you get on the green line and go into Prince George's County, which is where the green dots were on that map, we see the life expectancy is only 75 years. So in this 12-mile radius, we see a 9-year difference in lifespan. Let's look at another city, New Orleans, where I currently live. Clearly we see the blue dots are predominantly to the west. This would be Jefferson County, Parish. The green dots primarily to the east. Racial segregation creates an infrastructure that facilitates the exposure to health risks and differential availability of resources that's protective of health. I added New Brunswick here so you can get an idea of the community where you are to see that this phenomena is a national phenomena. In every city, every state, you see a similar pattern. Here in New Brunswick, you see large Hispanic population in this portion of the city, and we see more of a Black population to the west, followed by the red and blue dots representing Asian and white Americans. 3 distinct communities in New Brunswick. And then finally, I'll do my hometown of New York, just to show that I'm not being biased. This is New York City. To orient you, this would be the Manhattan Island, and it's okay. Manhattan Island, this white area here, this rectangle is Central Park. Just to give you an orientation, Central Park is white because of course no one lives in Central Park, right? Which I can attest to the fact that that is not accurate because many years ago when I was doing social work, working with homeless people in New York, I used to call homeless people living in Central Park. So I personally knew people that were living there. Nevertheless, New York City is clearly a rainbow. We see clearly demarcated areas where one color is separated from another color, I've drawn this circle here around Brooklyn because, as you know, people from Brooklyn believe that Brooklyn is the center of the universe. And of course, Brooklyn is in fact the center of the universe. This mass of green here in Brooklyn, central Brooklyn, is where I grew up. Community called Brownsville. Brownsville is 86,000 people living in a little more than 1 square mile. And how do we get 86,000 people into 1 square mile? We do that by building up. Brownsville has the highest population density of any neighborhood in New York City, in New York State. This is the building where I grew up. And this is the elementary school that I would have gone to had it not been shut down about a week before I was to start classes. That building has been laid dormant for the last 50 years now. And as you can see, you even have the foliage coming up from trees that have grown throughout the building and through the roof of the building. It's been abandoned for so long. A little bit about the food environment here, street scenes of this neighborhood. Here are some photos from Baltimore, my adopted hometown, where I've lived most of my life now. These are corner stores. So malt liquor, lottery tickets, cigarettes, some foodstuffs. This picture is from a store that was just about a block away from my office at Johns Hopkins when I worked there. And this is my favorite. If you know Baltimore, this is North Avenue, just off Greenmont, L&M Liquors, and I swear I did not Photoshop this sign. They sell beer, wine, and medicine. And I appreciate the truth in advertising here because the medicine that they sell is, of course, the elixir for the ills of poverty, malt liquor. Malt liquor, of course, is not beer. Has about double the alcohol content of beer and is sold in much larger denominations. These are just a few bottles from my private collection of malt liquors that I collect in cities around the country. I have this bottle of Miller beer here just to give you a sense of proportionality. These are 40 ounces of malt liquor. And then of course, there's the 64 ounce of Old English. We did a study once, Baltimore, to look at the location of where these products were sold. And we found that they were almost exclusively sold in census tracts that were predominantly Black and low income. So this infrastructure of segregation creates the environment whereby harmful factors can be at greater, have greater levels of exposure, and the availability of resources necessary to live a healthy life, or of course, are less common. So this issue of segregation impacts virtually everything we do in the area of health equity. And it needs to be in the forefront of our minds when we do anything, and including the COVID response, which I'll talk about in a moment. And let me explain another example of how this happens and how this creeps into the work that we do as public health researchers. So I'm going to tell a story about an article that I was asked to review for a really fancy journal. I won't say the name of the journal. I'll just say it was a journal published in New England, and it is a medical journal. But they sent the article to me. The article's title was something like "Race Differences in Firearm Use Among Adolescent Males," or something like that. So unfortunately for the author of this article, the data they used was from the state of Maryland. And unfortunately, the journal chose to send the article to be reviewed by someone that lived in Maryland, me. Before I go on with the story, I want to say that this was a blinded review. I have no idea who the author is. It's possible that the author is in the audience here today. And if so, I would just remain quiet. I don't think you want to claim this one, but it's not personal because I don't know who you are. So as I'm reading this article, I see that they're comparing white and Black adolescent males and their use of firearms. I see that the Black males are predominantly from East Baltimore, which of course I know because I'm literally sitting in my office in East Baltimore while I'm reading this article. The white males in the study were predominantly from Garrett and Allegheny County, which is in the western part of the state, in the Appalachian Mountain region of the state, which I also know because I used to vacation. The white males are shooting long guns or rifles. The Black males shooting mostly handguns. The white males are shooting at, I don't know, rabbits, deer, wildebeest, whatever they're shooting at. The Black males are mainly shooting at each other, right? Now, I know a lot of statistical trickery to get data to confess pretty much anything, but I don't know the statistical trick that makes this a comparison of race differences. This is a comparison of urban versus rural, maybe. It's a comparison of one type of hunting culture versus another type of hunting culture, maybe. But in order for you to have a comparison that is a race comparison, we would need to have Black males from Garrett and Allegheny County be in that study, which there are some because I personally saw them with my own eyes while I vacationed out there. And you'd have to have white males from East Baltimore in the study, which there are white males living in East Baltimore because I personally have seen them as well with my own eyes. Now, this is an extreme example that I give you, but I'm giving you this extreme example to make a point. The way that segregation affects the research that we do, and therefore our understanding of the phenomena that we're studying, happens in much more subtle ways as well. So another story, this is about a colleague of mine when I was at Johns Hopkins who had done a study of a condition. I won't say what the condition is because I really don't, it's not relevant who the person is or what the work was about. But this was a study of patients that had come to the hospital and they were looking at disparities, race disparities between Black and white patients and their outcomes. So this person asked me to review the article before sending it to the journal and to get my opinion about whether it was ready to go. So I read this article, and as I'm reading it, I see that the white patients mostly came in the study through the ambulatory care center, right? They went into the outpatient center, and then they were admitted once they got there and went into the hospital. The Black patients took a very different pathway. They more commonly came into the emergency department and then was admitted into the hospital. So if you're coming to the hospital through the outpatient center, that means that you were referred there by a physician that has admitting privileges at the hospital, that you had an appointment, so that most likely you were not in crisis when you came. If you come to the hospital through the emergency department, you don't necessarily have the advantage of being seen by a physician that has admitting privileges at the hospital. It's much more likely that you were in crisis, which is the reason you came to the emergency department. And then the nature of the crisis was such that it was determined that you needed to be admitted to the hospital. So we would expect that patients who come through the emergency department are more likely to have negative outcomes or worse outcomes than patients that come through the ambulatory care center, just by the nature of the way they came into the hospital and the fact that if you come into the emergency department, we don't know who you'll be discharged to. Will you be discharged to a physician in the community? Will it be a physician who will be able to access Johns Hopkins medical records and follow your course of treatment while you were there? If you come through the outpatient center, of course, you were admitted through a physician in the community, and you'll be discharged back to that physician's care, and that physician will have access to the records of what happened to you in the hospital. So I went back to this person. I said, I read this your paper, but looking at this, I think you have a methodological flaw in your study. I would suggest you not submit this study to the journal because I don't know that you've demonstrated racial disparities here. And this person thanked me profusely and then went ahead and submitted the article to the journal, and it is now published and likely has now added inaccurate information to the research literature. So these are extreme examples, but true examples of the ways in which segregation impacts what we know or think we know about disparities in health. So in order for us to really study disparities, we need to find environments where people are living under similar conditions or the same conditions with the same health risks and availability of the same resources to protect health. So we did a study, we looked to identify communities around the country that met the criteria where there would be a racially integrated community without significant race differences in economic status as measured by median income and high school graduation rates. And of the 168,000 census tracts in the United States, we identified 425 that met the criteria of having at least 35% Black and 35% white residents and no differences in income or educational levels. Fortunately for us, these census tracts were in, two census tracts were in Baltimore, and they were contiguous, and we went into that community to do this study that I'm going to present to you. These two census tracts together were about 44% white, 51% Black. So you can see there is no significant race difference in income, no substantial difference, only a small difference in poverty rates, and educational levels were also equal between Black and white residents of these two census tracts in West Baltimore. Looking at the distribution by sex, we see a similar pattern, no significant differences in the distribution of gender here. So you have here in this neighborhood, the closest thing that you're going to come to finding a naturally occurring environment for experimental environment to do a true race disparities analysis without the confounding of segregation and the confounding of socioeconomic status. And we went in over 12 weeks, we were fortunate enough and able to interview 42% of the adults living in that census tract. And so I'm gonna just show you a little bit about the representativeness of the study we did. This is comparing the census data to our data, showing that we are, I think, pretty representative here of that community, which I would expect to be if you have 42% of the adults in your study. Distribution of sex also. So the study the analysis that I'm going to show you here is looking at blood pressure, hypertension. And what we did is that we replicated portions of the protocol from NHANES and from Health Interview Survey. We replicated their protocols and collected the data exactly as they do in our sample so that we can do similar analysis in both data sets, a national data set such as NHANES and in our data set, EDHIC, to see if we find the same disparities that they find in the national studies once we don't have to contend with the confounding from segregation or socioeconomic status. And these four models that I'm showing you here are from four different studies. What we did was we went into the research literature. We identified four different papers that were using NHANES to look at race comparisons of blood pressure. So each of these models represent a different paper that had been previously published in the literature. We then went into NHANES and we replicated the analysis that they did in their paper. And then we replicated that analysis again in our sample to see, do we find the same results, okay? And we see a clear pattern across all of the studies that were published, all of the studies published. And when we replicated those studies in NHANES, we found odds ratios above 2, meaning African Americans having more than double the odds of whites of being hypertensive. But when we replicate that in our study that does not have the confounding of segregation or socioeconomic status, we find that the disparities are dramatically smaller in each of the models that we replicated. We explain up to one third of the disparity in hypertension in one of these models here. So we know that these social determinants, essentially what we've done here is that we have turned these social determinants, these structural factors such as segregation, into a constant rather than a variable, and therefore we've taken it out of the analysis and control for it through study design rather than controlling for it through data analysis, which is the way that we typically try to address the social determinants of health. When you look at other conditions that we studied, we find similar patterns to what we found in hypertension, in fact, even more so. And hypertension, diabetes, the national data finds that African Americans have 61% greater odds of being diabetic compared to whites. But in our sample, we find no significant race difference in diabetes. Obesity among women, the national studies show 87% greater odds of Black women being obese compared to a white woman. In our sample, where people are living in the same neighborhood under the same very challenging social conditions and economic conditions, we find no race difference in obesity among women. Hypertension, we've discussed previously, and this is the use of preventive health services, which was interesting. In the national study, we found a non-significant effect, but a trend towards higher rates of use of preventive health services among whites. We also did not find a significant effect in our sample, but we did find the trend in the opposite direction, which we also thought was interesting. So to sum it up, we find that while we teach in our classes that African Americans have double the odds of being hypertensive than whites, and often we attribute that to some biological characteristic rather than a social characteristic, we find that that is not accurate, that there is not. We find evidence that there is not a genetic reason or biological reason for African Americans to have double the rate of hypertension compared to whites. And we find evidence, again, that disparities in diabetes and obesity are a function of social conditions that people live under and not necessarily behavioral and certainly not biological differences between race groups. So the point here is that we have racial segregations in racial disparities in health. And that is the topic for today, a topic that we address a lot often in public health schools these days. But there are, in fact, four great disparities that are like a web of causation that cause each other and are caused by each other. And it requires a comprehensive view of each of these disparities if we're going to make progress in addressing the health disparities. We know that education is one of the best documented determinants of health, but we also know that children with health problems have a more challenging time developing their education, getting an education. We know that people go into prison often because of we know that there are extremely high rates of illiteracy among people in prison, and that if you're in prison during your adolescent years, you're not getting an education, not necessarily in school, and therefore less likely that you will develop educationally. We know that wealth determines who can afford quality health care, quality legal services to keep them out of prison. And the best way that I can think of to ensure that a people will not develop wealth is for them to be in prison between the ages of 17 and 35, which is the period of our life where most of us develop the human capital necessary to create wealth. The health and wealth relationship is probably the best documented relationship in the research that we do. And we know that people go to prison because of undiagnosed and uncontrolled mental health conditions, and that people often come out of prison sicker than they were when they went in. Obviously, the health and wealth and education relationship is well understood. So I'm going to take, before I get back to talking about COVID, I'm going to take one more opportunity here, which I like to talk about another sort of tangent that's really important to me. I like to make this point whenever I have an audience to speak to. And the point is this. I'm sure many of you, if not all of you, have heard that there are more Black men in prison than in college. But I've always thought that, found that a difficult idea to accept, given where I grew up and the number of people that I knew that had gone to prison and had gone to college. That just didn't track with my personal experience. It just didn't make sense. So I went to the Department of Justice and the Department of Education and pulled their data to see, is it true that there are more Black men in prison than in college? Because that just didn't make sense to me. And in fact, what I found is that in 2006, which was the first time I did this analysis, there were 86,800 Black men in prison, which is an outrageously large number. But that year, there were in fact more Black men in college than in prison. But then I said, okay, well, the age range in prison adults is going to be from 18 on up, but in college is typically going to be a smaller age band, like 18 to 23, something like that. So I tried to match the two data sets up. The best we could do was age 20 to 29 because of the way the data was presented. So in the age group of age 20 to 29, there were 310,000 Black men in prison, 480,000 Black men in college. So again, more Black men in college. So then we said, okay, was there ever more Black men in prison than in college? And we found that going back to 1980, which was when the earliest data that we could get from the Department of Justice and Department of Education, we found that there was never a year where there were more Black men in prison. So that statement was untrue when it was first said, and it never has been true. There are, in fact, more than 500,000 more Black men in prison, college than in prison. So if nothing else comes out of this talk today, I ask that you join me in my crusade to get this terrible myth and lie to stop spreading, because it does have implications for healthcare. Because how is it possible that we can believe something that is so untrue? If I told you that there were more Asian men in prison than in college, you would never believe that. You'd just assume that I was wrong or that I was making that up. But somehow, so many people are able to believe something that is so untrue about Black men, and it has implications for the way that we respond to Black men, Black people, when you encounter them in the healthcare setting as well. So this leads to where we are now in the pandemic response. the early data are showing disparities in vaccinations. I was recently interviewed about the data for Louisiana and warned the reporter to be very cautious in interpreting this data at this early stage for a number of reasons. For one, the 2 vaccines that are available have not been fully approved by FDA. They have emergency use authorization, and currently they are authorized for use in only two populations: healthcare workers and people over age 70, well, 65 based on CDC standards. Each state has a different age range. And so the comparison is not, as in Louisiana, the reporters were doing, only 10% of the vaccines have gone to African Americans, but African Americans are 32% of the state's population. That isn't really the correct comparison. The comparison is what proportion of the healthcare workforce is African American and what proportion of people over age 70 is African American. Also, we had an extremely high number, 38% of respondents to people who were vaccinated did not respond to the question on race. So we had a dramatic amount of missing data. We will need to wait a little longer before we're able to really get into the issue of whether or not there are disparities in COVID vaccinations at this point. I'm not saying that there aren't disparities. I'm just saying it's a little too early to draw that conclusion. But what's not too early is this idea, this understanding that African Americans are highly distrustful of the vaccine and report in polls that they are less likely to agree to accept the vaccine. This comes from that history of distrust that has been generated by the history of untrustworthy behavior. So this is where we are. And if we're going to reach herd immunity, or I prefer community immunity, if we're going to reach community immunity, we're going to have to be somewhere between 70 and 85% of people who are vaccinated. And that will never happen if African Americans don't get vaccinated. So I was asked by a reporter about this issue of vaccine hesitancy among African Americans, and who told me that Elvis Presley took the polio vaccine on the Ed Sullivan Show, which was the biggest television show at the time, and Elvis Presley was the biggest star at the time, and asked me, was there somebody who was there an Elvis Presley of today that could reach the Black community? I suggested that there probably wasn't a single Elvis Presley who could do that for the Black community, but rather that we needed to have many different voices, many people coming forward, showing that they were willing, many trusted voices. And here, President Obama has indicated that he would get vaccinated on television live in the hopes that it would encourage some people to do the same. 2 presidents of the historically Black colleges in New Orleans, both friends of mine, have come out strongly in support of the vaccine, both participated in the vaccine trial. And what they found was that they were widely criticized for coming forward and doing this. But where we are now is that this is me getting my first shot of the Pfizer vaccine earlier this week. Where we are now is looking at strategies to make data-driven decisions about how we ensure equity in the distribution of the vaccine. And we've incorporated this issue in Louisiana, where I'm working on this. We've incorporated this issue of segregation and community factors, social determinants, in our strategy for distribution. So this map, in this map, we're looking at Louisiana and the various parishes of Louisiana, which are counties in New Jersey. We, using the CDC's social vulnerability index, we identified the communities that were most socially vulnerable, and then and that's represented by the different colors of the parishes. The darker the color of the parish, the more socially vulnerable that community is determined to be by CDC. The dots represent the distribution sites that we've in our first pass identified. And we overlaid that over the social vulnerability map to see where were the gaps in our coverage? What were the communities that would not be covered if we followed a more traditional process for determining distribution sites? And we've identified numerous locations around the state that would be disadvantaged if we use the existing healthcare infrastructure to deploy the vaccine. So that we've now developed strategies of how we're going to reach these communities that don't have natural distribution points and high levels of social vulnerability. We've developed this, what we're calling strike forces, which will be mobile teams that will go into communities and working with trusted voices in those communities, such as clergy, other social organizations, set up mass vaccination events within communities that CDC has determined to be highly socially vulnerable and where there's a lacking infrastructure to reach people. And we think that this data-driven strategy will help to mitigate inequities in COVID vaccinations in Louisiana. So I know I've thrown a lot at you there. I'll stop there and happy to answer any questions or discussions that you may like to have about any of what I've just presented to you this morning. Thank you.
Thank you for sharing this information with us this morning. We have some questions that were submitted by audience members prior to this morning. So we're going to start with a few of those, and then we'll take some questions from the live audience. That's okay with you? So the first question that we have is, what current efforts are underway to better understand and address vaccine hesitancy in Black and Hispanic communities?
Yeah, this is a big
Elaborate on that.
This is a really big problem, and there are a number of strategies that I know about and some that I'm involved with. The idea is to get trusted voices to come forward and talk about it. I think that the federal government made a lot of mistakes, especially around communications in their response to the pandemic. Calling it Operation Warp Speed was a very unfortunate choice. It emphasizes the speed at which the vaccine is being made. So we're developing a vaccine over 10 months rather than the usual 10 years or longer that it takes to develop a vaccine. So how did you do that? They did not communicate well about how that was done, and just simply that it was done quickly and it was a miracle. And trust us, it's safe. That's kind of what the message has been. Well, it was done without cutting corners, and it was done without cutting corners because, first of all, the amount of money that the federal government threw at this vaccine was unprecedented. The number of teams that was around the world working on the vaccine was unprecedented. And the new technology, the mRNA technology that has been recently developed, makes it possible to develop vaccines much more quickly than you previously have been able to develop vaccines. That certainly was not presented to the general public for people to understand that there was new technology that made this possible. Also, the regulatory process was sped up. So usually you'd have to go step 1 to step 2 to step 3, and each step would have its delays. These delays could add years to the process. Instead, the regulatory process was sped up so that people acted at each step much more quickly than normally, which moved it through more quickly. And the other thing is that usually everything is done sequentially. So first you complete trial, phase 1 trial, then you go to phase 2, then phase 3, then after you've proven it, then you start manufacturing. What they did is that each of those phases overlapped, and they actually started manufacturing the vaccine before phase 3 was completed, which was extremely risky, of course, but it sped up the process of getting that vaccine ready to be deployed. So if you explain to people how it was that it was done so quickly, I think people could understand it, but I think they just did not do a good job of explaining it. So the mistrust begins to build. Then if you remember early in the pandemic, when testing was unavailable, we in New Orleans, we had drive-up testing. Drive-up testing sites were not in Black neighborhoods. So Black, and you could not get a test if you wasn't in a car. So African Americans could not get tests. Then couldn't get tested. Then once that was determined to be the case, then we moved away from drive-up testing and we started doing mobile testing, driving into neighborhoods and doing the testing. And then we had much more equity in how it was being done. Now people are saying, well, African Americans should be in the front of the line to get vaccinated. Well, what's the thinking behind that? Then you say, okay, well, when we needed to be tested a year ago, you didn't bring the test to our community, so we couldn't get tested. But now you've got this hastily prepared vaccine and you want to bring it to our community and try it out on us first to see if we die before you deploy it. This is the narrative that develops because of the actions and the way that things have been handled. So the distrust comes from a very real place. It is very logical. I completely understand the distrust. And in fact, if there wasn't distrust, I'd be concerned that something was wrong with people to not distrust the process. Having said all of that, the vaccine is safe, has a very high safety and efficacy profile, corners were not cut. And just because the communication was so bad, it doesn't mean that the vaccine isn't safe. And as you saw in that photo, I have personally been vaccinated, and I recommend to everyone that when the opportunity comes for them to be vaccinated, that they should be. How do you deal with that? There are a number of efforts that I'm aware of. I know the National Medical Association is working on, bringing their voice to this. I know that a number of large Black churches are banding together nationally to bring the clergy to it. I'm working with a group of African American members of the National Academy of Medicine. We're working on an open letter that we're going to be publishing soon, and we're going to create a video talking about it, trying to speak to the Black community about why they should trust the vaccine and get vaccinated. So these are some of the efforts that I'm aware of. I know that the CDC has a program that set of grants that they funded to try to get vaccine information out into communities of color, and NIH also has a program. And so I know there's a lot of people working on this issue, but trust takes time. It took a long time to build up this level of distrust. It's going to take a long time to dig out from under it. And in the short term, we just have to rely on trusted voices and not try to get people to trust the government, which is currently not highly trusted.
So staying with the theme of promoting the vaccine, how can healthcare professionals support healthcare providers to encourage the uptake of the vaccine and not overburden them?
Yeah, I think this is another area where we have, I was talking to a colleague at Penn who was telling me about how the African-American healthcare workers are also hesitant to be vaccinated. So I think it's getting the information. So the healthcare workforce are people that can understand how the vaccine was produced so quickly, if it's explained to them. And I'm saying that we just have not done, I shouldn't say we fix that simply. The federal government has not done a good job of explaining what Operation Warp Speed was, why they called it that, and how it was that they were able to make that vaccine so quickly. And I do think that healthcare workers can understand it if you explain it to them. So I think for that population, they just need the information, which has not really been given to them.
Okay, we're going to change topics, and we put the questions in topical areas. So the next topic area was moving towards an equitable and anti-racist society. And the question there is, what can healthcare and public health trainees do to help reduce inequalities in healthcare?
Yeah, I think there's a role for everyone. So you said healthcare workers?
The question is for health, what can healthcare and healthcare trainees do to help reduce inequalities in healthcare?
Yeah, I think what we can do is, one of the things that we actually are working on is we need to look at the ways that we bolster racist beliefs in the work that we do, and largely unintentionally. I don't think people are intending necessarily. It's the way that we've all been trained. We came through a training system that produces set of beliefs and ideas that I think help to support the disparities, production of disparities and inequities. So for example, the way that we deal with race in the research we do, the way that we deal with race in the teaching we do, the fact that we teach in our classes that African Americans are double the odds of being hypertensive, and that there's something in the biology of African Americans. We never present, well, what is that gene? What's the name of the gene that's producing that? If the next time you hear someone say that, challenge them to name the gene or the variant that exists in only one race group and is producing the outcome. They cannot, because it doesn't exist. And this kind of thinking creeps into our brains in very subtle ways we don't think deeply about it. So we have to look at our curriculum, and we have to embed in our core required curriculum, not just I'm sure Rutgers has an elective course on health equity. That course needs to be moved from the elective section of your curriculum
to a requirement.
or required curriculum. It is a matter of a core competency. If you do not understand health equity, you are not competent to work as a public health worker in the 21st century. It is a core competency of the work that we do. So that's the first thing we need to do. We need to ensure that every person who is being trained in any aspect of healthcare be trained in the importance of health equity and understand these issues, period. We need to be looking at who we admit into our programs. So right now, especially in medical schools, we place a great deal of emphasis on organic chemistry. Ask any practicing physician how much organic chemistry is involved in their daily work, and they will tell you essentially zero. You ask them how much social work is involved in their daily work, and they'll tell you, I feel like I am a social worker doing counseling half of the time. Why are we admitting people on the basis of organic chemistry and not on the basis of their humanity, which is what we want? We want the outcome to be a physician who is, or a nurse or another clinician who is humane, but yet we're focusing on standardized test scores and organic chemistry. So how about we start there by saying, okay, what are the characteristics that produce good healthcare workers? Let's select people who have those characteristics and then provide them the training that will make them competent to deal with the society as it currently exists and not as it existed in the 1800s.
Thank you. So the next question is addressing the role of the vaccination in racism and disparities. And so the question is, how can we address structural racism through vaccination communication, priority populations, and access?
Well, I can talk about the way we're thinking about it in Louisiana. What we're trying to do is, as I showed you, one thing that we're doing is we're trying to be very intentional about identifying, well, what are the communities that, if we follow normal practices, which are the communities where the inequities would occur. We're trying to predict what that is and then develop strategies of how do we get to those communities so that we can follow what we know to be successful strategies. We've got this vaccine that needs to be kept at -70 degrees, right? And once we thaw that vaccine, we've got 6 hours to use it. So it's going to be hard to get that vaccine into rural areas, into some urban areas, and to be able to deploy it, right? So we're trying to be thoughtful about that. So if we follow the normal practices and only give the vaccine to facilities that have the freezers, we know that there are going to be communities that are going to be left out. So we're trying to be very thoughtful about, well, let's do a simulation and let's figure out what are those communities that we can predict are going to be disadvantaged. And then we deploy the normal strategies to get to the communities where it will work. We identify the strategies where those normal strategies will not work. And then we say, okay, now let's figure out how we can get to those communities at the same time that we're getting to these communities using different strategies. That's the way you've got to think about it. It's got to be at the forefront of your mind, and you've got to be trying to predict where those inequities will occur.
We have a question from an audience member, Kate D. Don't know how we unmute her.
You might have to unmute yourself.
Kate, you're going to need to unmute yourself. Okay,
Hi, can you hear me?
yes, we can. Go ahead with your question.
I was just wondering, I had two questions. I'll ask my first, and if time allows, if there's room for the second. But I was wondering, when you were talking earlier about the papers that have been published, can you talk a little bit about, do journals typically have bias committees in place to look for things? Is there kind of a good representation of people of color? I apologize for the dog in the background.
I have never heard of a journal having something like that. The gatekeepers are the reviewers and the associate editors. So it goes to the reviewers, and I guess it's a matter of who happens to be the reviewer and whether that reviewer would pick up a bias. For every bias that I picked up reviewing articles, there's probably another 5 that I didn't pick up reviewing articles, and I'm looking for the biases. So there's I don't know what a strategy would be, and I've not heard of any journal that's had an effective strategy to deal with that.
Are there other questions from the audience at this time? Kate, you had a second question?
It's a little bit more specific, but I was wondering something that my husband and I had noticed. We are both guardians of a developmentally disabled adult that's in a group home setting. At the direct service provider level, there is an extraordinarily high proportion of people of color, and we were seeing a lot of vaccine hesitancy. I know that you had discussed before about kind of local and community-based initiatives. But do you know of anything, because these agencies ultimately fall under the purview of the DDD, like that is happening at the statewide level, to kind of encourage this, to attack it from different angles, or not to your knowledge?
Yeah, I don't know anything beyond the local level. So typically the way public health has worked is that the federal government comes in with advice and resources and coordination, and then the states and state and local government, state and local health offices is where the actual implementation happens. This time, the federal government did not play a traditional role in much of pandemic response, so that left every state to fashion its own response with limited resources. And so states is doing its own thing, which is why we have such varied outcomes across the states. So I really wouldn't know what would be available in New Jersey.
Okay, are there other questions from audience members? Okay, go ahead. Is it Shineri?
Inyara Osuji, hi.
Go ahead, thank you.
Hi, Dr. LaVeist, thank you so much for your presentation. So my question is about the role of healthcare providers and practitioners. I'm doing a study of African nurses and nursing students. And they've got some really interesting stories about the treatment of patients, particularly patients of color. And from what I've seen in the literature, and I've looked at some of your work as well, it looks like there's a lot of stuff on how patients understand their interactions with providers, and that's useful. But I was wondering if you know of literature or work that looks at either interactions, like ethnographic work, interactions between providers and patients that show us the dynamics of how racial discrimination might play out in those interactions, or other like surveys or other research that looks at the providers. Because as much as we talk about issues of structural racism and even language of structural competence and like cultural competence, I'm often seeing that this thing about like the providers and their biases is often missing.
Yeah, there are a couple. There's some work by Michelle Van Ryn, who's out in Minnesota. She's done some work on that in the past, which, interviewing providers. There's also the work of Kevin Schulman, who is down at Duke now, who did a really, I think, really important study. This is back in the 90s, late 90s, where physicians looked at vignettes, videos of patients or actors who were portraying cases, and he varied the race of the actor, and asked the provider what their treatment recommendation would be, finding disparities and what they recommended. There've been some work like that. There's not a lot that I'm aware of, but you might want to start with those two authors and then see where they've been cited and whether they're newer studies that I'm not aware of.
Are there questions from the audience? We have time for a couple of more questions. We have a comment from an audience member. It says, I'm a public health student and noticed my intro courses in undergrad did not address systemic racism at all, even in discussions about health disparities. I'm grateful for discussions like this and looking forward to learning more as academic curricula shift to include more voices and studies inclusive of people of color. So thank you. She's saying, so thank you to you.
Yeah, and I'm hopeful that will come. I mean, I'm working on an initiative along with your dean. Dean Perry is on this initiative as well, with the Association of Schools and Programs in Public Health, to develop competencies that we would propose to the accrediting body as being required for accreditation as a public health program in school. So I'm hopeful that we'll get there. We're already working on that at Tulane, so we're implementing that regardless of what the accreditors do. But we're hopeful that this will become a national standard, not just enlightened deans that decide to do it.
I think we have a lot on our plates from AAMC. I'm sorry, from ASPPH to do this work, because I'm on one of the subcommittees, along with, I think, with Perry and a few other people looking at some of these issues. And we're having sort of the same issues here at Rutgers, like how do we fix this problem? So we have several committees working on it and trying to include it in our new strategic plan. So we know it's a problem.
And it's going to take time. I mean, we can't expect it to get done overnight. Many of our instructors don't know the content, right, and really can't teach it. And so I don't think that we have to consider that and so there's going to have to be some retooling that happens, so it'll be something that will get done over time. But we have the desire, we have people in place that are working on it, and we've got leadership on it now. So I think we will get there.
We have a question in the chat box. It's, how can public health inform or break down silos within medical practice?
I'm sorry, give me the name, give me that question again.
It says, how can public health inform or break down the silos within medical practice?
I don't know that public health can break down the silos in medicine, but I do know that more and more medical students are getting the MD, doing the MD and PH. I think encouraging that, we have a very old program at Tulane. We're celebrating our 50th anniversary this year of the creation of the MD and PH program. I think that we need to support that and support as many clinicians getting that public health training as possible, having that broader perspective. That's all I can say about how we can do that. But I think our influence on them would have to be indirect.
All right, we have another question from Suzanne.
Hi, can you hear me okay?
Yes, we can.
Great. Thank you very much for a very eye-opening presentation. I would like to know, from the point of view of someone who has been buying into the myths and the narratives in the public literature, for which I apologize, how can I shelter myself from those erroneous narratives? What should I be reading you know, if not the public media, if we know that even the medical journals are getting it wrong?
Well, I think what I can say, look, I sat through the same courses as everyone else and didn't challenge what was being taught. So I sat there and was being told things like, you know, African-American hypertensives should be prescribed diuretics, and whites should be prescribed calcium channel blockers and beta blockers. And I heard all that stuff too. And it wasn't until I started looking at the literature and say, well, is there science behind that to find that that's just some old wives' tale that continues to be passed down in medical school? I didn't start challenging it until I, you know, kind of gotten out of training and started to you know, be independent. And I think that's the solution, is that you have to challenge what you're told. So more Black men in prison than in college. You know, most people just take that and just assume it's true because it was stated. I mean, I heard President Obama say that once. So we just accept it as being true. And I think as researchers, we need to be using everything. And you know, I don't believe anything until I can see some data to support it, especially if it doesn't ring true to my personal experience. And that whole prison college thing just didn't make sense. I grew up in one of the toughest neighborhoods in Brooklyn, and I knew more people who had gone to college in prison, and that just didn't make sense to me that was true. So I looked it up. And so that's the way you can inoculate yourself from that, is that you challenge things. It doesn't hit your ear right. You say, okay, what's the data to support that? Is that really true? Where's the science to support that? You know, what's the study that shows that? What's the name of the gene? What's the name of that race gene that's causing hypertension and diabetes and cancer and stroke and schizophrenia and high rates of homicide? I mean, what's that gene that's doing that? And if somebody can't answer that, then you lay bare the fact that people are operating on the basis of old wives' tales and not on the basis of science.
Thank you very much.
Okay, we have a couple of final questions in the chat box. The first one is, what are your thoughts? Oh, it moved that quickly. What are your thoughts on how to best include race in clinical research? Should we even include race, ethnicity as variables when looking for predictors of an outcome?
Yeah, that's a real challenging issue. We was getting into when I was able to teach classes, which I missed. We would in my health equity seminar, we would engage these kinds of questions that I always enjoyed. That is a really tough one. If we stop using race in the research, then we lose the ability to document that we have inequity. But if we continue to use race the way that we use, we can also continue to bolster myths, right? So how do you deal with that challenge? It's not so much, my advice is not to stop using race, but to be more thoughtful about how you use it and how you interpret its meaning. And then you have to also do sensitivity analysis. Okay, we found this, and this leads me to conclude that this is something about the person, the race of the person, something about them and their race that's producing this outcome. Is it something about them, or is it something about the broader context? So we look at national statistics, for example. We look at the national data, and we see disparities in infant mortality rates or life expectancy or whatever it is. And then we conclude that there must be something about those people that's causing them to have higher rates of infant death or lower life expectancy. Rather than saying, okay, well, wait a minute, what's the context in which people are living their lives? Is it perhaps the context, the exposures that they have that's producing these disparities? And maybe what's being demonstrated in these statistics is that people who live in certain type of neighborhoods have a higher rate of infant mortality and a lower life expectancy. And it just happens that race determines who's more likely to live in those types of neighborhoods. So it's thinking more deeply about things when it comes to race, not assuming that race is biology until somebody can actually show you the name, give you the name of the gene, and until somebody can present me with that name and show it to me, I'm not willing to accept that race has anything to do with biology, except for the characteristics that determines your skin color, which we know not to be correlating with all these health outcomes that we know are differential. So it's thinking more deeply and going beyond the superficial level and just saying that difference is indicative of something that's causal.
Okay, we have a question from Jeffrey Robolino.
Yes, doctor, that was an excellent presentation. I learned so much. I'm a physician by trade. My specialty is anesthesiology. And I did go to Rutgers undergrad, and I did go to UMD&J in Stratford. So I got my DO. So, and that, I agree with you that, you know, organic chemistry I've never used organic chemistry in my practice, even though I use a lot of critical care thinking. But I agree with that. But I wanted to know in my practice, even as a nurse, registered nurse or paramedic or an EMT, over 35 years in medicine, I don't want to say my age, but I admit that
35 years old.
I admit that I've had implicit bias in how I treated my patients. It probably came when I was a physician, and it was a case. There was an African-American obese, I don't remember the age, getting bariatric surgery. And I treated her like she did not have enough education for me to explain the anesthesia consent or the operation. The next day, because I was in bariatric month, the next day I had a white male, 50-year-old obese patient for the same surgery, and I spent less time educating him. I went home that night, to be quite honest with you, and probably cried, and I was sickened to myself because I am not a racist. I'm Hispanic who grew up in the projects in Hialeah with residential segregation everywhere, drugs everywhere. And I got myself out of there and became a physician, went up the ladder. So what is your take on implicit bias and how, everybody has bias, but how, the way I try to get rid of it is before I even see a patient, I self-evaluate myself and control my thoughts and try to think before I speak. But what's your opinion on implicit bias?
I think that, well, first, thank you for this question and your very, very honest story. I think that devaluing Black life is an American value. And Africans, Latino Americans are Americans too. So this is an aspect to this country, and it's something that permeates all people. And your personal background doesn't make you make you immune to it either. And I think your story illustrates that. What's important here, though, is that you're able to be reflected. There was something that you found to be unacceptable, and that you're willing to make the change as a result of that. And I think that's where we begin to make progress around implicit bias, when people are willing to look internally, look at themselves, and identify where they may have biases. I think that the human brain is organized in a way that bias is simply going to happen. We get so much information, so much input constantly into our brains, and we need ways of organizing that information. And we do that by creating categories and creating stereotypes, right? Because we see patterns in the data. And that's the way our brains are organized. Every single human being has that same issue. So it makes perfect sense to me that a person of any background could fall into these unconscious biases, which is why I don't believe that simply increasing the diversity of the workforce is going to resolve the problem. It's increasing the diversity of the workforce will produce more people like you who are willing to say, well, wait a minute, I need to take a look at myself and figure out what was I thinking there, what's going on? And I think that's a tremendous value for people who have the sensitivity to think that way. But the inequities are a simple function of the way the neuroscience of the way the brain is organized.
Another way that I help myself is I took a couple culture on diversity inclusive courses on my own, and it will be kind of cool. I don't know if there's research. It would be kind of cool. There are implicit bias tests out there. Be kind of cool to get people who take these culture diversity inclusive courses and then do an implicit bias test before, and then take the courses, and then some time after take it again. For me, it definitely helped me. And obviously being an MBA student and learning in my first semester, learning all about structural racism and residential segregation, which I lived, it definitely helps as a physician. So I don't know if there's any research about that, but thank you so much though for answering my question. I really appreciate it.
Yeah, well, thank you, and thank you for being so honest and being thoughtful about this topic.
Thank you.
But
Thank
you
you,
can
sir.
be an example.
Thank you.
All right. Dr. LaVeist, we want to thank you for being with us this morning and taking time to answer everybody's questions, either from the audience or the ones that have been pre-submitted. But on a final note, we would like to ask you, we have the vaccine. We know that we're having problems with distribution right now, but what do you see as being hopeful out of this? Do you see into the tunnel?
Yeah, I am hopeful. As I said, what we've discovered is that the federal government really has not been playing a sufficient role in this response. And we have a public health infrastructure that's set up where each level of government has a role to play, and the federal government hasn't been playing its role. We do now have a new administration that has already begun to play its traditional role in response, and we're very hopeful. So we've been getting 58,000 doses of vaccine per week, which is not even remotely close to being enough for us, for the state of Louisiana. Some states have been in even worse shape than Louisiana has been. And even there, we're told on Tuesday how many doses we're going to get. Then the doses show up on Thursday, and there are fewer doses than we were told we were going to get. So we've made plans based on a number of doses, and then we don't get the doses that we expect to get. And therefore, we have to cancel appointments and things like that. And that's really been tragic. The president is now promising to use the Defense Production Act to ramp up production of not just the vaccine, but other things that we need, like the syringes. And we are expected to have at least a 10 to 15% increase in the number of doses that we'll be getting by the middle of February. So I'm very hopeful that we'll start getting more. Another thing I'm hopeful about is Johnson & Johnson vaccine, which we expect that they'll be applying for emergency use authorization within the next week or so. That vaccine is a single dose vaccine. We don't know the results. I don't know the results of phase 3 trial, but I'm hopeful that their results will be on par with the results from Moderna and Pfizer. And if that's the case, if we now have a single vaccine that doesn't require the extremely cold temperatures to maintain, this now gives a vaccine that we can take into the rural areas, that we can have mass vaccination events, because if we have leftover vaccine, we don't have to worry about them expiring so quickly. It'll be a huge advance, assuming that it's as effective as the Pfizer and Moderna vaccine. That's something that we'll be getting within the month, if things work out the way that we hope they do. Now there's some challenges there. Maybe it won't be as effective. So Pfizer and Moderna is at 95%. Maybe the Johnson & Johnson may not be as high. And then we're faced with the issue of, do we take the vaccine with 80% efficacy into disadvantaged communities? And then what is that narrative? We'll have to deal with that challenge when that comes. But I'm hopeful that Johnson & Johnson will be as effective as the Pfizer and Moderna. And that'll be a huge help, that we'll have herd manufacturing arm which would ramp up, give us more vaccine, but also make it a lot easier logistically to get into hard to reach places with that vaccine.
Again, I want to thank you. I'll see you at ASPPH meeting, and I'm going to turn this back over to Kelly.
Okay, thanks, Terry. Good to see you.
Thank
You
you.
too.
Thanks everyone for attending today's 21st Century series, and Dr. LaVeist for your really insightful and engaging presentation, all the engaging questions and the chat discussion. There are lots of resources over there on the chat, so hopefully you all were able to check that out. I also wanted to thank Dr. Lassiter for moderating the Q&A session here at the end, Karen McCarthy for coordinating a lot of logistics with Are You Here, and Michelle Edelstein also for coordinating with the Office of the Dean. Dr. LaVeist, thank you so much for your dedication to health disparities work in the research world, but also in the real world, in the community. We're very grateful for your time today and wish you the best. Thanks.
Thank you, everyone. Have a great day.
Thank you, everyone.